Welcome all to our virtual conference on improving access to behavioral health care. I'm Ron O'Donnell, clinical professor in Arizona State University College of Health Solutions, introducing our speakers today. Our topic, of course, is of interest to all of you, reforming payment for mental health providers. And we have two excellent speakers today. First of all, Dr. Lesley Manson from Arizona State University will talk about value-based payment, what it is and how it can help access. Second, Lauren Finke, the Senior Director of Policy at the Kennedy Forum, will speak and talk about the state of mental health parity and how achieving it can help access. And in fact, our speakers will kind of trade off back and forth throughout the presentation and work together to keep you entertained and informed. So please, Dr. Manson and Dr. Finke, begin your presentation. Thank you.
Thank you, Dr. O'Donnell. And as Dr. O'Donnell had just said, we actually have kind of a collaborative approach to this presentation because we really feel like overall, these strategies that we're going to talk about today is really influential in helping to improve mental health care access. So I'm going to go ahead and flip some of these slides. Lauren, would you like to introduce yourself in any other way today?
Sure. Lauren Finke, Senior Policy Director of the Kennedy Forum. Really nice to see you all. I'll just say that we work with providers all the time, and it's been a really, really critical component for both understanding some of the issues that are going on and so that we can make big policy changes happen. So really, truly couldn't do the work without all of you who are working in the field. So really happy to be here.
Thank you. Neither of us have disclosures to note. And today we're really going to be talking about mental health access, ways to incentivize mental health providers to join third-party payer commercial plans, and talking about payment reform and pivotal ways that we can really expand access for mental health care. Lauren?
Sure, yeah. So the current landscape of what we have going on, there's a mixed bag. We've got some challenges ahead of us, but there's some really great areas of opportunity as well. And I think our goals as advocates has really been open access to all clinically, medically necessary mental health care services. And that has been a guiding light. I think will continue to be that. And just to review some of the challenges and opportunities, I think incentivizing insurers to have standards that are in line with what you see on the medical side, on the clinical side, being more outcomes focused, reimbursing for care at the right times and the right places, and not using that as a barrier, but really making sure that timely access to care is a big important piece too. I think making sure that providers and members of a team providing care are all sort of aligned in incentives, and those incentives are aligned with payment is really important. We do have some limitations that well, we've got a really great opportunity in the Federal Parity Act, which I'll talk about later, and in state parity laws. And there's also limitations to that. There's
Can't hear you. Someone said something important.
I think there's a lot of, in the parity space, there's a lot of uncertainty from providers, and so I'd like to make sure that we're focusing on some of those things today too, so that you have the tools that you need to sort of understand where parity rules can really be used in your favor in order to really get care covered and really overturn some of these things that I think plans just kind of universally deny, even if it's illegal. So we'll talk a little bit about that. And I already talked about this at the beginning too, but I'm making sure that those clinical standards of care are really aligned and incentivized in our reimbursement system. So I'll go through parity now, and if folks have questions, well, how do we? I guess we'll either maybe put them in the chat, and we can make sure to go through them. I know this can get wonky really fast, and I want to make sure that we're not doing that to people. Parity is the thing that makes everyone in my family's eyes glaze over when I start talking about it at like Thanksgiving. So I like to think I've gotten better at it, but I want to make sure it's useful for you all. And really what parity is. So insurance coverage for mental health and addiction services should be the same as insurance coverage for other medical conditions, which means that is messy and as limited as our regular healthcare system is, parity only protects up till that point on the federal level. And so we've got some state things that we can talk about too that can become bigger protections that kind of oversee this larger parity role, but federal parity is really making sure that we're aligning our mental health and substance use disorder care with the same sort of standards of care that we have in the healthcare system. So same terms, same conditions, it cannot be more restrictive. So if you are offering inpatient care and the medical surgical side, you have to offer it in the mental health side. Which is why we talk about parity being a fundamentally anti-discrimination law, that it really is about the access to that care. And it really is about access to that care. It's not just about saying that it's there on your plan documents. If it functionally is making people not be able to access medically necessary care, then that is a parity violation. So I'll go over the next couple slides, some of the federal and state protections and also some of the limitations, but that is overarching, that's the overarching goal of parity, and that's what we're always trying to shoot for. And I think, you know, in a lot of states, Arizona included, regulators are really wanting to push for this, and they're really, they can be good partners in this work. I think they sometimes just need some guidance on where these issues are actually happening, so that they can know about these things outside of just their regular audits. So they can, it really is important to be aware of that. So next slide. So the federal parity rule signed into law in 2008. It was a bill that was sponsored by the founder of the Kennedy Forum, Patrick Kennedy. When he left Congress, he founded Kennedy Forum to continue the implementation of this Federal Parity Act. Insurance plans do not have to cover behavioral health treatment, but if they do, it must be comparable with other coverage. So at this point, the landscape for most plans is that they are providing mental health coverage. Under the ACA's essential health benefits too, that really expanded. So nearly all plans have to offer this coverage, and therefore they have to comply with federal parity. Big exception is Medicare. There's some big gaps too for TRICARE. Medicaid, it applies to. I think there's a misconception that it does not apply to Medicaid. It does. I think Medicaid agencies are way farther behind in even understanding how that kind of applies to them, and also because denials work differently in a Medicaid system than they do in the commercial system. So I just wanted to note that, because that's something that people are entitled to in Medicaid as well, but often I think it's overlooked. Moving on. Can I also move the slides, or am I allowed? No, I can't. All right. So the main protections in MAPIA, Federal Parity Act, is that health plans cannot do a number of things. They cannot charge higher co-payments. They cannot have other out-of-pocket expenses for behavioral health care. So these all kind of fall under this umbrella of financial requirements, and all of those things, they are not allowed to put as more restrictive on or as a reason for limiting payment. So just really, this is, I think, maybe the most important piece for this group, but I would really really want to highlight the co-payments out of pocket, out of how they go for when they make you go for out of network care or charging out of network rates, and when they can start kind of like fighting back and forth on that is limited to. Physical limitations, we call them quantitative limitations, which honestly are areas where we see less of the violations happening because they're so easy to quantify, and so regulators can more easily get to them. You know, things like number of visits, number of days of service, things like that. So we see less violations there, but that still does happen. And so there are rights around that. And then where we see the most of this is, I talked about how quantitative care, like the number of days, is pretty easy to quantify. There's other things that are not as easy to quantify, and we call those the non-quantitative treatment limitations. And that's all the Medicaid or all the managed care practices that kind of fall under that. So that's sort of when you're moving people out of network, or your levels of care placement, things like that, that aren't always so clear of, you know, what is inpatient care for eating disorder, like residential treatment, exactly the same as, you know, some treatment for inpatient care for other physical conditions. And so you do sort of have to make arguments, and it gets a bit squishier. I'm not sure. Okay, this is great. Okay, so this is what I really want to focus on, is just really common examples of the parity violations in under that NQTL category. So things we see a lot: more frequent, more burdensome additional processes on prior authorization requirements. So if they're making you go through lots of hoops or calling you a bunch about different things, and they wouldn't be doing that on the physical side, or they have like a very specific process and they don't really follow that, that's a big piece. Frequent concurrent reviews to see if care is medically necessary. And I'll just put on the side there that we often argue that it's a parity violation to not require, or to basically claw back in this way. And also that if we were realigning with clinical models of care, that you would have approval for the full course of treatment. You wouldn't have to sort of do these every 3 or 5 days sorts of things. And so for the full course of treatment, you would have that. And that applies in many areas in the mental health and addiction space, but I think it applies especially when you're looking at the higher levels of care and addiction care and medicine. So that's one area. More frequent fail first protocols, step therapy, stricter within this, I think too, when you're switching plans, not honoring what had already been tried before under other plans if you're the same provider. Stricter medical necessity criteria for behavioral health than they use for surgical or medical surgical. I would argue almost everything kind of falls in that bucket, and there's a few things that we can talk about within that. Stricter network admission criteria for behavioral health providers, just the hoops that have to be met in order to even be put on a panel or on a network can be considered a parity violation. And then formulary designs around behavioral health drugs and putting them on higher tiers. And, that kind of gets at a lot of these other issues of co-payments and things like that. So that's a number of things. If you're working in the field, I'm sure you could also come up with some of these. I saw some head nods. I really hate when I walk through these and people head nod because that means they've experienced it. So yeah, these are all areas that there are a lot of protections around parity for, and the payment piece I think is really important too for us in this discussion.
And it looks like some folks are acknowledging, yes, they've experienced some, massive parity violations in the past, and reminding folks that most of your state entities have great parity groups working and to join and collaborate. It looks like Becky had said, I work for an insurer and some questionable practices at times.
Yeah, I mean, I'll say some of the frequent things that we've heard are like, even for training for on the medical surgical side, that people who are doing utilization review get better training or more frequent training, and people on the mental health side don't as much, or sort of the lack of peer-to-peer review on the mental health side. We see a lot of fighting on, this is more on the patient protection side, but of, fighting for out-of-network care once their plan has been unable, it is not successful to find them treatment. And I'll just tell you a story of a friend that I recently was helping get care and was looking for inpatient mental health care, and they said over an email, we can't find anyone in the whole state for you. And then when we talked to the plan later, they said, well, we're going to charge you out of network because we cover things and we don't have basically out of state, out of network provider. And we're like, well, you told us that you could. So that's a very common, right? That's like an egregious parity violation. And I think they're so used to sort of reviewing cases like this and not having people and providers fight back that they kind of just wait until they get their hands slapped. And of course, I'm overgeneralizing. I think there's been some progress in select plan behavior. And I think as we, especially on the Medicaid side, as a lot of these commercial plans, or when we move into Medicaid MCO models, I think maybe we'll start to see some improvement, or we could start to see on the other end, maybe some struggles in Medicaid. So I think that's why it's important to making sure that we know what our rights are on both sides of these things. And I'm having a very hard time reading all of these questions as I'm talking. So let's see. Clarify why there are laws in the books about parity, but they can just be violated. Yeah, so they, I think, and I'm going to tell you maybe my cynical opinion first, and then I'll tell you the other one second, but cynical opinion being that they're going through lots and lots of care and mental health claims are not a big piece of it. And it is because of those non-quantitative treatment limitations I'm talking about, it's very hard to like when you're asking plans for plan documents to really find those parity violations as a regulator. And we've made some good progress in sort of being able to fight back about those. But I think historically it has been very hard, like plan practices of giving huge tomes of paperwork and being like, so this is what we have for this patient. And then the regulator is sitting there just expending all their administrative energy trying to find those things, which is why sometimes you see open appeals cases take years, depending on, the violations. And so I think that's historically been it, is that there's not a lot of them. And so those are sort of just lower on the totem pole of priorities. And they do take so long when they get wrapped up by the regulators. We've made some good progress federally. There is, under the Consolidated Appropriations Act in 2021, the regulators essentially said, you must, health plans, give us documentation about your parity compliance, and you must use these specific forms. So instead of saying, instead of them giving a bunch of forms, they really have to describe it in the framework that the regulators are asking for. I think that's made a big difference. And I'll just advocate here that under that same Consolidated Appropriations Act, state regulators have the ability to ask for those analyses, and the state regulators who have done so have found widespread parity violations. And so that is information that can be requested of state regulators if you live in a state where you'd like to see more of that. And so I think that's it. Another piece too is because we're in that non-quantitative treatment limitation space, I think sometimes regulators don't fully understand how they can regulate. These are very complicated topics. I won't not name the state, but I've had a regulator in the state say, we rely on you guys to let the Parity Kennedy Forum and advocates to show us when there's like trends of parity violations happening so that we can kind of go after and look at what's going on. And so I think that's another area where advocacy is really important and where it's really, really valuable to bring, grouped concerns to plan or to regulators. We often hear regulators say, well, that's a one-off, I think. And so we'll just think about it as a one-off. But if you come together, I think that's why it's helpful to work with, state organizations and the guilds and really bringing forth issues together so that you can bring those batched and say, we've seen 20 of these. And I'll say a good example too. In California, we have a 38 addiction treatment centers who have been really religiously, every denial they get, they've been writing down who the denier is. They've been writing down the criteria they've been using. They've been writing down the reason for denial. And they found some really amazing trends that even the regulators were not aware of. And we were able to bring those to regulators and sort of solve some of those issues with them. And that would not have happened without, I know that's an administrative burden, but it really made a big difference to bring those forward. So yes. And let me keep going. Reviewing provider manuals with the state team, found dozens of parity issues. Absolutely. That's another thing. I think there's some low-hanging fruit, and sometimes you have to be like, excuse us, this is the low-hanging fruit here. This is in written plan documents. In California, we have a law in the books that that you can only use the clinical models of care or clinical nonprofit professional association criteria for the clinical decision-making for utilization review. So, ASAM for addiction care, Locus and Cal Locus for mental health. And we, for years, we saw plans that still were showing using interqual criteria or using MCG criteria, which we know just are more restrictive in the utilization review process than for the nonprofit association. So we basically had to go through, and whenever someone saw that, and that still happens too, by the way, in a denial letter, sometimes we'll see those things still be mentioned. And so that's a big red flag too, because that's an additional state parity violation, but that is really helpful to bring to folks. So yes, it does unfortunately happen when you see the low-hanging fruit like that. That's not been picked yet. It can be frustrating. Would Medi-Cal disallowing same-day visits for mental health and medical needs while other private insurances and Medicare cover them be an instance of a parity violation? It depends, and I'm happy to follow up offline or talk with you through that if we have more time at the end of the call. But it sort of depends, because sometimes that's a billing issue and sometimes it is an actual violation. So we can talk about that further. Probably the same for a PPS rate too, but I'll look through these, and I absolutely can share resources. If people want to put in the chat what states they're from too, I can also link you up with some of the state parity advocates too that may be able to help as well, and that could be helpful. And very curious to hear more about the ASAM changes, because that is something that is sort of used as a baseline, as many of you know, in Medicaid, but also for, in California with the commercial side too. That's the clinical criteria that will need to be used. And I'm the contact for California. That's where I live. So please email me too, and we can talk about that. Okay. What is on the next slide? I'm not sure if there's one more on parity. Okay, yeah. So key areas for reform. And Lesley, please step in here too if there's areas that you'd like to speak on as well. But this is just thinking through some of those issues that I was just reviewing. Obviously, prior authorization reform is a really big piece. And I'll also say for prior authorization reform, the American Medical Association has done quite a bit in this area and has had some successful wins. And so, if you do, well, I think it's actually in the resources slides of this anyway, but it's very much worth looking up sort of what they've detailed out, helpful for providers as well. So within that, reducing overall volume of prior authorizations as a goal, increasing transparency on the requirements and that's both in plan documents and in documents shared with providers, and making sure that those things are up to date and transparent, and that you know that what you're operating off of is what they're operating off of. So that's important. Promoting automation, I think, where it can be implemented in the prior authorizations and sort of the billing and all those things where, and we just hear from providers having to wait for extremely long periods of time. And I think with the recent, was it the United data breach, providers and hospitals are waiting a very long time too. So I think, automating some of those things can be really helpful. And then just ensuring timely access to care, which I know I said in some of the earlier slides, but just how important that is. I think sometimes when we're trying to implement a lot of these protections, we might get the protections, but they're just so slow, and that kind of ruins people's ability to stay in care. That ruins your ability to treat them long-term as a provider. And so I think that has been, while maybe not a parity effort, I would consider a big parallel effort that's really important to keep in mind. And then utilization review practices in general. I mentioned the addiction providers that had that the tracking system that has been exponentially helpful. We know that folks that are working in the eating disorder space are also seeing a lot of these sorts of denials. And so we've started to work with them to make sure that they can start using that. It's a tracker that we created that's like a Google Doc, and then people send it back to us when they have information on that. And then we bring that to regulators, although of course you're welcome to do that and use it. So we'll make sure that's a resource that's added. And then the peer-to-peer review process, I think this is maybe no surprise to folks, but it is a surprise to folks when they're not working in the mental health care field, is just how often you'll have a reviewer who has no training or experience in the conditions and the, no education. We see this a lot with addiction providers or addiction utilization reviewers have no addiction experience, or child adolescent psychiatrists should be reviewing child and adolescent utilization reviews. So not having those the same education, the same training, being really unaware of really what training they're getting at all from the health plans to implement some of the parity things that are in law that they have to implement. The peer-to-peer process is really important. And if I could guess, I would think that's increasingly going to be an area for advocacy and reform. But I do encourage you, if you are, you sometimes will get the names of or actually oftentimes get names of reviewers on denials. But if you're starting to see trends, I mean, there's providers we talk to, they're like, oh man, I always know when I get a call from Dr. So-and-so that it's going to be a no. Like that's a big problem. So that's something that we'd like to do more around. And to Megan Bailey's question about whether there are any resources on national best practices to guiding prior authorizations, the AMA documents have a lot of that. It's really amazing what they put together, and we're in alignment with them on a lot of those things.
And I believe some of those links are in the resources, and we'll make sure that folks have access to this information after as well. So everything we're talking about here today is really about expanding access to mental health care for our communities. And just to kind of give a little bit of some recent data so folks are aware of the current landscape of access for our populations. According to recent data in the past 3 years, about 14.9, so 15% of children aged 5 to 17 have received mental health treatment, and 8% using medications, 11% undergoing counseling or some sort of therapy services. And we have a significant amount of children that experience mental health, emotional health, and behavioral disorders that also receive care in different types of places like schools, general physical healthcare centers, inpatient, outpatient, hospitalization units as well. So we have a lot of individuals that do need care and do need access. And then we have individuals that are of adults that are also receiving some sort of mental health care and treatment. So about 21% have received some form of mental health treatment, but less than half of adults who require mental health care actually are receiving it. So we really need to look at why is there a gap? And there's many reasons why there's a gap. And then some of our national entities and guilds have really promoted some of the reasons for this. And especially after COVID, there's been a lot of surveys through AMA and APA relating to why providers are no longer taking commercial insurance, why providers are leaving really sometimes even their professions. And they're really seeing an increase in symptomatology. So they're seeing an increase in mental health symptoms and challenges that are happening. They're seeing an increase in patient needs and reduced capacity in their environment. So they're being overloaded. So not only with not having availability for patients, new patients, but also long wait lists, with averages is about 70% of providers having wait lists now. So these things are really important, and these add into these challenges that we're all experiencing in healthcare. We also have to look at how can we increase capacity for our mental health care. And there's lots of recommendations that have been made related to really bringing on an integrated care focus and lens. Of course, stronger parity laws, as we've been discussing already, improve commercial insurance coverage and mental health provider access related to that. And soon we're also going to talk a little bit about some of the strategies related to that, as well as some of those challenges that we know are out there regarding. We also want to look at improvements in telehealth and telehealth practices, Medicaid expansion, and some of the no wrong door models. As you've seen, as Lauren represents California, out of California, they're really trying to push that no wrong door model related to individuals being able to access mental health providers and care through all systems that are present. So that's criminal justice, community health, worksite models, school-based and primary care models as well. It's really trying to enhance how we can be able to provide access to care across the continuum for our communities. Now, when we're thinking about this, one of the biggest pieces is we do want to incentivize our mental health providers to expand access and to be able to join third-party payers, commercial payers, because oftentimes there's a lot of hesitancy to do that, and there's a lot of reasons. We've just discussed some of those. Lauren was bringing up lots of the concerns related to that. Some of the big concerns are related to administrative demands. So we need to be really looking at reducing administrative demands for mental health providers. We need to look at streamlining credentialing and contracting processes, really simplifying and expediting the processes for mental health providers to be able to join networks and get on, incentivize them to be able to do that as well. Try to reduce the burden by really reducing those claim submission processes, pre-authorization, okay? really look at prompt payment practices. We're looking at about 30 to 60-day wait on most commercial insurance payments, and some of them are looking at 90 and more days out. And especially now when we have some of these new kind of IT attacks and things that are happening, we're looking at even longer waits and breaches related to payments, which can really impact especially small provider groups and independent providers. And it really leads them to not want to join these commercial insurance plans. We also want to look at transparent reimbursement rates and fair reimbursement rates. Those of you who are providers on here probably know the multiple different types of rates that are out there and how you're seeing these really extreme values in rates. And there's really not something that is saying, here is the bottom, this is what everybody needs to pay. We're not aligned in any way in process of that. So we really need to be looking at conducting regular assessments of reimbursement rates so that we can ensure that we're really covering mental health services and the best quality of care. We want to also provide supportive services to our providers so that they can understand and be able to join our insurance providers and really develop collaborative partnerships with them. So I want to just pause here for a moment to see, have other people had any questions or experiences related to administrative demands and problems when it comes to insurance and mental health? Anything people would like to ask or note right now in the chat box?
One of the issues that we run into pretty regularly is around our aged and disabled, the Medicare, Medicaid, and them getting caught in that loop of whether the provider can bill Medicare, whether or not they're going to get the denial, even if they can't bill Medicare and they're covered under Medicaid. And it's really influencing, obviously, that population. I don't know if you have anything around that.
Yeah, Lauren, do you want to speak? Go ahead.
Yeah, I mean, not to punt it to others, but the Legal Action Center does a lot around dual eligible work, and that's a very complicated field, and I won't mislead you all by saying things that could be potentially wrong, but I do know that we talk a lot about how to sort of utilize the protections that are on the Medicaid side and making sure that you're not getting delays just because they're dual eligible too. So happy to sort of suss out some of those resources too, but Legal Action Center does a lot on that.
Okay, that's good to know. Yeah, it's not so bad when we're covering both. It's a pretty seamless process in the background for us to kick it from one to the other. But it's more difficult when it's like Optum, United Healthcare, somebody external that isn't as mindful about getting that information processed. So yeah, I'd be really interested in that.
Yeah, and Megan notes that new allowances for LMFTs and professional counselors to bill Medicare will hopefully help. That will definitely help with expansion of mental health care services, and that's what we want. So hopefully we'll see that. Hopefully starting next year, we'll get some data from that. I know there was a little bit of a backup and delay of some folks being onboarded into that system. So many of you might already be in process for that, which is awesome. So there's already some of these pieces that are starting to expand to offer more services for mental health. We also want to take it through the lens of looking at it through telehealth reimbursement. So telehealth access and quality of care, looking at telehealth parity laws to ensure telehealth services are reimbursed at the same rate as in-person visits, prompting equitable access to care for folks, investing in telehealth infrastructure in rural and frontier areas, especially because those areas still have individuals that do not have cellular data coverage and are unable to not only access in-person, but also cannot access telehealth services. Really help with provider and team training to ensure proficiency in telehealth delivery, and really look at education outreach initiatives to raise awareness and adoption of telehealth services. So we really do need to be moving and supporting our clinicians and our communities to be able to see access in many different types of ways, and ensure we also have quality assurance and standards related to this access. Becky says the flip side of that is to ensure that we're concerned about losing availability of in-person services. Yeah. So a lot of people start to have those conversations related to, if we start to expand too much in telehealth services, are we going to lose the folks that are coming in, or are we going to have a lot of providers who really want to be able to work from home, right? And so they're saying, hey, I'm going to be able to have more flexibility. And so we do need to be looking at these incentivizations. How do we provide support so that we can have providers both be on at an office in person, but also maybe be able to support their life and their, balance in their own lives with being able to practice at home sometimes as well. So it is a challenge, not only for us related to kind of policies and thinking about nationally, but organizational levels.
Well, and
Yeah,
I think in general, we just haven't compensated people that have to pay for brick and mortar and all the stuff that comes along with that very well. And so we really need to take a thoughtful look at how are we compensating people.
It might be revisions related to looking at how we're identifying some of our compensation. And we're going to talk a little bit about that when it comes to the value-based care pieces. We're still coming from a model really looking at relative value units and how we're looking at billable pieces. But we might really want to look at expanding some of that, especially since COVID and how there's been so many transitions and extremes as far as cost increases for folks. We need to also look at addressing disparities in reimbursement rates, and that's including our reimbursement rates related to our commercial payers. So we can look at our data, and we should be learning from our commercial payers related to the data of how they are really providing support to address disparities, and really looking at how are and who is actually receiving care, especially when we look at mental health care. And so I think it's really important to be able to look at these pieces and be able to help foster kind of a reimbursement landscape that's more supportive to our mental health providers. This also leads to embracing value-based contracting incentives for a higher care delivery so that we can look at more fair compensation as well. Oh, Megan says, I don't want to derail anything about with an FQHC that is location bound, providing telehealth to patients outside the geographic allowances, especially telehealth, has come up at all. Let me read that again, Megan. I don't know. With an FQHC that is location bound. Oh, I see. And providing telehealth to patients outside of those. So yeah, so there's definitely some limitations when it comes to different types of telehealth practices. So not only are states very different when it comes to their policies and procedures, both for medical providers, but also mental health licensures are distinct. And so it is important to kind of look at that and not only look at whether or not your mental health providers can provide telehealth within the state in different regions and different areas, and what are those legal requirements. And then also with your commercial payers, is there a specific entity or area that geographically that they have different types of compensation or policies or procedures related to? Those things can be very confusing and can really kind of keep us from being able to provide the best access.
And I'll just add here too, a key area of advocacy for us has been really highlighting those disparities in reimbursement rates. And you can make some, I mean, I think often what we hear is arguments of why we can't increase reimbursement rates is that there's already a workforce shortage, and there's sort of these circular arguments of being able to pay for all of it. But there's some data that's supposed to come out. Today is April 4th. In the next couple weeks, a big new report that basically looks at the Milliman reports are really important for seeing disparities and advocating for those. And we've often heard an argument from plans that that data is just so outdated, and things really changed in the COVID and post-pandemic world. And so after that, some of that data doesn't really matter. And I think what you'll see in that report is that that's not the case. And then also just thinking about, or that report also talks about differentials by type of provider. And I think that can be really helpful when you're able to see really what the differentials are from the medical surgical side for your specific type of specialty, and being an advocate for what your rates are and what that looks like to stay in network and or to stay on a panel. So the reimbursement rates are abysmal, as everyone on this call probably knows. And I think sometimes they can be hard to advocate for a raise on because they're just sort of talked about in this large nebulous field instead of by provider rate or by specialty or whatever care you're providing. So I think that's where some of the parity rules can help too.
And what a great example, Megan, you just put into the chat that is very relevant to what Lauren was just saying. Here you are meeting with individuals about Medicaid, and they Google, oh, looks like your pay rate seems to be in a good spot. So there we go. Rather than really looking at the data, thinking about patient complexity, thinking about socioeconomic factors, thinking about the specialty of your mental health providers or your other providers there and what they're actually providing and doing. So it can be, these are all the challenges that everybody is meeting and seeing.
Yep. That was
really
the head of our behavioral health team for the state of Montana, the literal head of state government. That's their research. I had my intern Google it. So this is great. Resources, please God.
Yeah, I think the arguments we often hear around the market, I would just, that's frequently in my advocacy of well, if you need to incentivize providers to work on these things, that this is a high need field, if you do not have this number of folks, there's a number of things we can do to make that pipeline easier, and increasing reimbursement by need and by what the market is sort of demanding of providers when it is basically very artificially low compared to that is a big problem. So yeah, definitely an issue. I think there may be some good areas for advocacy in the future, especially when some of these reports come out that show how bad it is by specialty area.
And we need to also incentivize cultural knowledge and relevancy in care. So thinking about really helping to incentivize or bonus healthcare providers who are really taking it upon themselves to ensure that they're doing culturally informed training and demonstrating some levels of proficiency in delivering culturally sensitive care. So thinking about how insurance companies can develop reimbursement models that prioritize this and maybe even influence some of the rates related to that. Maybe even considering standardization or models for mental health care providers, medical health care providers to be able to follow and be able to implement, and aligning our financial incentives with delivering culturally relevant care. So this is something that can really be helpful and timely, especially when we're looking at some of the value-based metrics and opportunities that we have in healthcare, with really looking at payment reform in those ways as well. Of course, as we've been discussing here and there, some of the biggest recommendations that we might have as well, and especially I will focus in on, is alternative payment models and looking at your value-based care payment model expansion. Now, we already have value-based care models that are being adopted across the United States and Canada related to specifically things like physical health care. We also have some expansion models that have happened throughout the states and in Canada related to mental health and behavioral health care services, but they are very small still, and they are not really aligned with our physical healthcare models. And we're still looking at a very small number of eligible practices for the contracts. And so we're looking at a lot of providers that are getting incentivized to be able to join these insurance rates and these contracts to be able to have this. When we are seeing them, just to kind of highlight a few of them, we are seeing them in some of the new opioid health homes that have come across with really great supportive rates, really looking at the complexities of our patient populations and trying to provide more financial incentives for providers to see different populations and provide the best quality of care. We're seeing in our behavioral health homes, our substance use health homes that are coming up. We're also seeing it in some of the care management models that have been packaged, and some of those pieces related to integrated care. We are still seeing very small and little to no independent or private practice expansion. So again, if someone is a very small practice, they are typically not eligible for some of these value-based contracting pieces and the different real recommendations of incentivizing them to be able to demonstrate the efficacy and access for mental health care. You often will see our value-based care contracts going through our accountable care organizations, places that really are doing very specific types of episodes of care or have shared care savings contracting. And then in Canada, there's the Primary Care Health Transition Fund, and they also are doing quality-based procedures and integrated care homes and community health centers that are actually providing different types of models to help promote mental and behavioral health professionals to increase access and increase their value with the communities. So there's a lot of community outreach and marketing and advertising and collaborations related to that as well. So really being able to increase these types of opportunities for the United States and into other healthcare systems is really helpful. So hopefully we'll be able to see this expansion over the next few years, especially with some of our mental health kind of actions and focus at our federal level right now. I do want to note another comment into the chat. Megan says, unfortunately, the reality for private significantly ill folks is that medication resistant schizophrenia or DD with polysubstance, they need a lot of help. And that looks like lifelong. So really looking at some of the complexities of our patient populations and knowing, again, when we're thinking about really incentivizing our providers and looking at commercial insurance, looking at parity, looking at improved reimbursement rates and structures, we do need to look at those populations. We do need to look at those differences and how these individuals might need higher level, different types of forms of care. And that care may be more difficult to be able to provide. So we need to be able to incentivize that and support that and provide access.
And I'll add that wraparound models are maybe not exclusively called out on this slide, but I think are a really hopeful piece here. We've seen a lot of I guess depending on your state also, but a lot of big movement forward in Medicaid on those wraparound models. I'm thinking of coordinated specialty care for first or early episode psychosis. I'm thinking of the ACT models for sort of a number of things. We've seen success in Medicaid, and unfortunately, I think in the mental health space that Medicaid is the leader on that stuff, and so it is a little bit of a test case engine on Medicaid, but depending on the state you're in, some commercial protections there for getting that reimbursement. An issue that we've had a hard time with is getting payers to actually, or getting providers to actually bill for some of these services because they're so used to just not having insurance reimbursed for them. And if we don't have any tries at it, then it's really hard for us to point to it should be reimbursed because then the plans kind of get an easy out. So it's sort of unfortunately been a little bit of a vicious cycle since some of these things have come online and been applicable. So I know a couple people said they were in California. In California, in the regulations for the parity laws, they say specifically coordinated specialty care should be covered. We cannot get a provider to bill a commercial plan for it in California. And so that's functionally not happening. So that I mentioned that because I think that's a good area for advocacy as a provider, but also some of the Medicaid innovations that are happening, I think are good places to look for where you can kind of push for that in the commercial space.
And Megan and Liz both talk about, one question is, are wraparound services embedded in CCBHCs? And so inherently with the model of CCBHCs, it is a model where it's actually really putting action into having a wraparound service, but there are specific statewide promotions of what we call wraparound models, and there's action teams for very specific populations. And so those might be a little bit different. And so those might have different terminology or different looks as far as how those services are embedded. So as Lauren was talking about, some of those action teams in California that provide very specific types of care for in specific populations. Also in Florida, there's also those action teams that are also focused on wraparound care for our severe, seriously and persistently mentally ill populations. Oh, you don't have CBHCs authorized yet. Yeah. Thank you, Megan. So still, again, there's another advocacy area right there you just highlighted, is that, hey, here in our state, we are not having that. That's not being developed here, and that's not being supported. Whereas in other states, you do have access to some of these programs, which also give you an increase related to your expansion and your fees, your reimbursement rates, which is really nice. Some of these health homes and these wraparound services are really getting both their regular general rate, and on top of that, they're getting a per member per month rate to support it based off of their value outcomes that they can report, whether it's quarterly or yearly. Okay. So some of these tenets, when we're looking at really expanding and changing how we're providing services and we're being reimbursed for services, we really want to emphasize the foundational tenets value-based contracting and care, because this is what's really missed a lot when it comes to our organizations and the insurer providers really overall as well. We need to really emphasize performance drivers and standardized measures to improve our patient outcomes. We need to help and support agencies and individual providers with being able to identify and develop and be able to communicate our data. When we do implement value-based payment models, we can really promote a higher level of quality of care, cost-effective care that's really being monitored as well. And hopefully we can also incentivize engagement with our communities and populations that we're serving. So we really want to look at also providing efficiencies and effectiveness in delivering care through our value-based models and incentivizing, looking at screenings, promoting interoperational ability, especially with so many places now having EHRs and having large healthcare systems and medical neighborhoods that folks are really interacting with and having all these different types of services with. And really making sure that our transitions of care from care provider to another care provider are able to be coordinated and improved with that. And through the commercial insurers, we can be able to do that if they're willing to really work with us a little bit more and provide that support. And that will also help drive our mental health providers to be able to action and jump on some of these contracting plans. Of course, we need those financial incentives, as we talked about before, and those financial incentives to be opened up. So not just aligned with very specific types of organizational structure, but being able to open up to other types of independent and smaller practices as well, which up to this date have really not been able to join on the value-based contracts at all. So really thinking about how they can really help with coordinating care of our populations and working with other larger groups as well, really help with being able to reduce costs of care overall and help improving access. So really thinking about how we can incentivize those providers. When we're thinking about value-based care, I really always have to say there has to be transparency elements. So we really need to look at having a collaborative conversation with our payers related to how can we teach and train healthcare managers to be able to understand these contracts, what's required and how they can be applied. How do we really talk to all of our different types of providers that are receiving these, and especially those smaller provider practices and groups as well? How can they really understand what the requirements are, what they're signing up for, how this can really benefit them and incentivize them, how it can improve the care delivery ultimately to their own populations that they're serving already? And then how do we really discuss this with our communities, our patients, our stakeholders? That's really an important piece too, because according to our guilds, the transparency on how their healthcare is being paid has to be done as well. And so according to our guilds, when we do have patients coming in, they need to know how their services are being paid and what is being reported on. And instead, we have long paperwork of NPPs that are given out to patients that are really hard, that providers don't even understand and patients don't really have good understanding. So really having better transparency elements and communication related to it is helpful, as well as being able to provide more support related to EHR systems, data, practice transformation, billing and coding. Because again, we're still seeing on a regular everyday basis, our providers and even at large scale organizations, FQHCs, ACOs, large scale hospital centers always going, wait, what was that modifier? How come I'm not being reimbursed for this week and I was last week? What did I miss? What do I need to do differently? What is changing now? And we need to also make sure that as we're considering these contracts, as we talked about, ensuring that not only do we have parity for all of this, but we're also looking at things like telehealth aspects. We're looking at being culturally informed. We're looking at making sure our population is really being looked at. We need everything to be meaningfully understood and accessed. And that's not happening when we're thinking about a lot of these contracts. Oftentimes, what we're seeing is what we're nicknaming meaningless value-based contracts. So it's not really getting at what we would see maybe as providers or as patients and stakeholders in our community, what really is value for them. So having more collaborations where we can understand from our communities what is valuable for them when they're receiving mental health care, what is valuable for them when they're looking at access, and really taking that into consideration in the developing of these value-based contracts and incentives. So the next slide just really goes over a lot of pieces to make things meaningful and really recommendations for our payer systems and larger groups and entities to consider related to for advocacy and ongoing metrics related to making value-based care contracts and incentives much more meaningful. We know there's already pieces that are out there that are part of RAFs and HCC scores that go into some of these pieces of risk adjustments and value-based care contracts. But again, those things also kind of make it very meaningless, whereas individuals can maybe get a higher kind of incentive and pay for just having a major depressive disorder diagnosis on there, but that also doesn't mean that they gave them treatment. That didn't mean that the standard of care was met for treatment. And that didn't mean that my provider was even there providing the treatment that might be needed for that patient. So really making sure that we're looking even further at some of these pieces, as Lauren actually had commented earlier, so that we have the best advocacy and we have the best standards of care for our patients and communities. Someone had a question about, do you see Medicaid and Medicare doing any incentives? Yes, so there are already value-based care incentives that are being promoted through Medicare, just in general related to outcomes and specific, and then specific Medicaid offices across the United States have actually supported very specific initiatives, and they have payment incentives that are provided in as far as bonuses and increased payments when you meet very specific types of data reporting and patient care outcomes. And some of those are very low. Some of those are just access outcomes. Is there a mental health provider that can be seen within so many days of a service need? Have they been outreach to need? Do you have care coordination on board? What does that look like? So some of them are like that, and some of them are a little bit more very specific related to, did this specific depressive symptom management tool demonstrate a reduced outcome? So reduced symptoms after so many months. Are you seeing a reduction in suicidal ideation in specific? So there's also very specific practice pieces as well. Megan says, I understand big networks and patient panels. Yes, that's the difference, is that if you are very small, you're being left out right now. And that's really part of this, this talk here too, is making sure that we're not going to miss those individuals too. We really need to be having them jump on. And that's part of kind of this healthcare shortage that people start talking about in mental health, and even, you know, mental health and medical health. We're seeing that, of course, as well. But folks are reducing off. And so we really need to bring them back. We need to incentivize them to be back delivering care. And we need to incentivize them, even in small practices, to be able to be part of these larger networks, part of these larger pieces of care. And we need to be able to do that. So definitely. So we do have, both Lauren and I, some recommendations related to really being an advocate. And of course, you know, a lot of Lauren's work is related to that, and really influencing your payers and community, state, and national centers related to it. So let me click here. Lauren, do you want to speak first?
Why don't you go ahead and I'll chime in with things that I get most excited about.
Yeah. I'll leave a couple on there that I know you're going to get really excited about.
Okay.
But overall, really, there's very specific legislative updates and state recommendations that we really want to press. We do want to look at, I'll go with telehealth expansion, making sure that we have that. We want to look at integrating all of our mental health providers and all access, so there's no wrong door, no matter where they're going in for patients to receive care. I really want to, you know, expand Medicaid expansion, of course, and workforce expansion. That's including a licensure and credentialing for workforce expansion. There's been a lot of efforts related to looking at mental health in the terms of community health workers, even where we have expansion in some states, where it's looking at workforce expansions for mental health with our hair dressers, if you haven't seen those, and other types of community providers. There was even a Uber mental health driver expansion for a period of time as well, looking at our crisis response and prevention efforts really being supported through legislation so that we have more ability and stability related to be able to provide those services in multiple areas of community, and looking at those pieces of value-based contracting and health equity and cultural awareness initiatives being driven in there, and knowing our populations. Lauren?
Yeah, so no surprises probably coming out of my mouth, but there's a lot of parity work to be done. The federal regulators have put forth draft recommendations, and the comment period for those has closed, but they are planning on releasing those and finalizing those in the summer or late spring. We're not entirely sure when, and those will be, in our view, pretty comprehensive and another lever to be used for regulating. So especially if you're seeing some of the issues and being able to raise those to state regulators, but then also the local EBSA offices are a really important time for advocacy around that. There's a number of bills on making sure that network adequacy is there, that the panels, that basically there's transparency on what health plans are doing around that, and provider directories that are accurate, and that means making sure that the people that are left on those directories are people who are practicing on those panels, things that I think can help both provider and patient. I'll also note here, we've got, for those who are interested in state advocacy, we have multiple model bills, model legislation that we're happy to work with folks working in states on. I will say every successful bill we've had, we've worked with providers on how it will work. And so you're key to those things. And we have a model bill on those parity rules I was talking about, of making sure that they're aligned with the utilization review is aligned with clinical standards, and that things are not deemed medically unnecessary, not based on clinical models, or based on health plans' own internal metrics. And then we also have one on 988 and crisis services, and making sure that there can be commercial reimbursement for those things. And there's also some provisions on getting providers included in the crisis continuum and reimbursement. And so I'm jumping ahead a little bit. I know it's in the next couple slides, but I just wanted to focus on those a little bit. And those are some key areas. And I'll just skip ahead to, since we've already changed the slide, I'll just say what I was going to say, which is that I highly encourage you all to collect those issues and talk to the folks that are working in your states. We also have the Kennedy Forum has a state parity working group where folks that are working in their states can join. That's usually for like advocates, like like a NAMI Colorado, or a mental health America Florida chapter, or things like that, but there's no bars to that. So you're welcome to join that. It has been on hiatus for a little bit of time as we've sort of sorted out what we can provide the Kennedy Forum, but in that time, people have been sort of knocking down our door and saying, what happened to that to that resource that you did? And we were worried that it wasn't actually that helpful for folks. So it turns out it was. So we'll be bringing that back probably in the summer. And that is a great way to share resources and then talk to folks about what's working in their state. And the advocacy level would really encourage you all to meet with state regulators and share with them where you're seeing these issues. Joining your local guilds or state guilds, because they often will have hired lobbyists. They have a lot of resources to do that stuff, and making sure that they're on the pulse of what's going on is really important. And for those of you who are interested in documenting the utilization review issues that I mentioned, I'm happy to provide that Google Doc link, and maybe we can add it to I did not add to the slides before, but maybe we can have a different update. I hadn't thought about that until this, so that you have access to it as well. And I would just encourage you, if you are using it, just let me know so I know what states and who's using it, even if it's just like, hey, we found a couple cases every 6 months. That's really better than nothing for us. So I would really encourage folks to do that. And Lesley, I'll jump to you.
Yeah, thanks, Lauren. And what we can do is we can actually hold off on sending out this PDF if that's helpful, and then of the slide deck, and we can get those extra links to be able to put in for everybody so that it can be sent out. So we'll figure it out with some of the presenters team here with Dr. O'Donnell and Ryder, and how we can get that information to you all. But I would say the same things that Lauren's been saying related to joining those guilds. They can really help with moving that legislation, maybe working with the Kennedy Forum on some of those basic pieces, and then looking at some of those guilds to really help with lobbyists to be able to move things forward and get more of that support in your state related to that. Also thinking about rapid expansion of mental health services. There's been a lot that has been proposed over the years, especially within the United States, related to really our advocacy of funding mental health positions and support and payment within justice health systems, within school-based services. There's actually been a number of states that have gotten rid of copay requirements. As long as that individual is within a school-based system, then you can receive mental health care and not have to worry about any co-payment, and then that's supported through the state. So there's actually states that have done very specific kind of creative pieces to open up access and to provide additional support to mental health providers in their provision of services. So just kind of looking at that, as well as thinking about other types of supporter legislation related to training, certification, maybe even reducing some of the concerns related to a licensure, being able to look at more pathways for national licensure for mental health providers, being able to have more compact laws and being able to provide services in multiple states, whereas we know licensure laws are very different among different states, and some states don't even have the same licensures. They're distinctly separate and different and are unable to provide collaborative licensures when people change states, as well as thinking about some of the other types of enhancing licensure and access, like prescribing psychologists or psychopharmacology pharmacists that are out there now. So there's other types of support that we can see to provide mental health advocacy and help and assistance for our populations. And of course, even considering legislation for loan repayment. And there's actually been legislation that has passed in multiple states last year and this year already that support increasing very specific payments to mental health providers, both psychiatric and general mental health providers, just increasing their payment. So there's actually a legislation that's gone through that have given them grants that they can provide to mental health providers to supplement their salaries and engagement with communities. And they have very specific rules related to that. But those things have all been happening based off of advocacy and state groups that are there. And it looks like Lauren has actually already put those templates and forms in the meeting chat. So I'll make sure to add that to the references and support on here as well in our slide deck, so that people could have that as well. At the end of our slide deck, we just also have some references and resources for folks that people can go over. Okay, so there's some links and other pieces. So if people are interested, they can kind of look through some of these things and see if there's anything to be helpful. I'll stop here to just see if you have any other questions for Lauren or I. Oh, Megan has a question, Lauren, for you.
Would getting networks to team with the Kennedy Forum on these denial trackings be helpful for another state? Yes, if you would like to lead that work and say, oh, we are doing this in Montana, that's great. We have the most information in California because that's where I had the most networks and where I'm based. We also do a lot in Illinois and have been working with providers in Illinois. I'd love to basically know information from like what kind of cases they are. So we already have a lot on addiction. Doesn't mean we don't need more evidence of that, but I'd love to see, I mentioned the eating disorder groups are working with us now, but just across the gamut. So as much as we can show to regulators that this is an issue that happens across all mental health and addiction services, and that providers across the board are running into this issue and framing it as a bigger problem. It really is a large part of our advocacy. And I met with the United States Department of Labor last week and shared some of our initial findings with them. And I think they were very open to making sure that they were better understanding these things too. So I think I've been a little bit negative about, the ability of us to really fight the man in a lot of these situations, but the regulators are trying really hard. And I think they just really need our expertise as advocates, as providers, and a lot of times as consumers too, about where our struggles are. And so I know it's exhausting to have to do that day after day, but I really appreciate everyone's passion and energy on a lot of this stuff. It really makes a meaningful difference. And email me. I'll put my email in the chat for everyone.
Thank you, Lauren.
And I don't know if this came up. So we different provider networks in Montana, and I work for a bunch of them. Because I do a lot of audits for a ton of different groups, I noticed a lot of incongruencies and who was getting denials and that it wasn't universal, right? And that certain groups were getting audited on one finding and yet another group is getting away with murder. And only because I was doing this work did I see it. So I would imagine that getting kind of these denials organized would probably also help these groups capture revenues. And I think everyone's pretty motivated to do that because we're all limping along.
Yeah. Yeah.
This was awesome, you guys. Thank you.
And I think the biggest thing is being able to bring all those groups together to be able to do that.
That has been our most challenging part of our state advocacy work, is really making sure that it's an iterative process too. I think we had a lot of success when we were running our initial large bill in California. We had a coalition, and that was made up of the professional organizations that represented the psychologists and the psychiatrists and the child and adolescent psychiatrists and the marriage and family therapists and the social workers and appeals attorneys. And we just had sort of everyone there, and that was a really successful coalition. And we're still, we're 3 years into this bill being law, and that coalition is still writing letters to regulators and still documenting things and still showing up to hearings and bringing those issues forward. And when I started on this bill like 6 years ago now, you could walk into a legislator's office and talk to them about, you could say the word parity and they'd be like, I don't know what that means. And that makes sense that they wouldn't, because that's a very niche area. And now they're like, yeah, it's the big bill, the mental health access bill. So I just, like, the voices really, really matter in this space. And I know I keep saying that, but I feel like people don't believe me. Like, they think I'm just being like rah-rah cheerleader about it. I'm like, no, it like really makes a big difference. So wherever you are identifying areas, if you think you're seeing them and this could be a problem elsewhere, it probably is. And so very, very worth bringing those issues up.
I have a quick question. So hi to Lauren and Lesley. I'm super sorry that I wasn't able to join for the whole thing, that I had this schedule conflict, but I want to thank you both for participating today. One of the questions I have is, I'm curious what you both think is the future in terms of more mental health providers participating in with third-party payers. I mean, right now we have more mental health providers who are cash only than any other specialty, right? And how do you know? And I don't know if I missed this part of your talk. You might have talked a little bit about this before I was able to join too. So, so if I did, just tell me to. If I missed it, just tell me to look at the slides, and I'll go back and look at it later. But what are your thoughts about that? How do where's the mental health workforce going in terms of, do you think we'll have more participation in third-party payers over time? Do you think we'll have less? How do we encourage mental health providers to participate more with third-party payers? Should we? Because it's a big access issue, if people are cash only, that really can be an access limiter for a lot of people. So that's kind of my one of my interests.
I think that aligns with some of the things that Lauren and I had talked about earlier, is identifying some of the barriers that exist. One of those reasons why people both administratively don't want to be joining commercial payers. What does that look like? And not having parity when it comes to payments and access and being able to provide that care to the patients that they're seeing. And also not having support really with a reasonable, transparent payment, and really looking at what that could look like and offering more value and incentives to our mental health providers out there that are currently just doing cash payments, by being able to broaden their perspective of what type of support and what they can do by meeting with and collaborating with the commercial payer system. I think that can really broaden that. It's going to take a lot of time to be able to do that, because right now doing cash payment seems so much easier for a lot of people. I also think that we also are missing, just as another side of this, As far as regulation, oversight, reviews of cash pay providers, we don't have a system where we're really generally monitoring and ensuring the standard of care and ensuring what is happening with those providers. And so unless there's a concern, then we do, then that piece actually comes into play. And so really looking at how we can help also in that other side to make sure that there is transparency with those independent providers would be helpful too, because I think that might lead them to understand some ways that being on those, having more support from commercial entities could be helpful in their practice, especially if they're incentivizing payments related to their populations, related to them providing culturally informed care, right? Telehealth options, all of those pieces we talked about before. Lauren, did you want to add anything?
Yeah, I did talk about this earlier too, but just like making sure that those incentives are in place. So people will come into panels if it is more beneficial to them to do that. If they feel like they can get paid better and they don't have to deal with all these administrative burdens of having to find a network and have all these things that right now it's easier and better and more financially stable to be not in networks. And that's a huge problem. And that's why I think it's so frustrating when we hear payers mention that there's a workforce shortage. There's sort of like this undergirding assumption that they're making that, providers are not owning up. They're not doing what they need to do. This is there are not these, you are all very good-hearted, providers are good-hearted, but that's not that's not going to make you a profession, right? That what makes a profession is that you're able to put food on the table, that you're able to have a good quality of life, that you're able to do this, just like all the rest of us choose our jobs. And I just sort of think about, spent many years still in the nonprofit world, but spent many years as a very much in the nonprofit world doing grassroots work and getting paid like nothing. And it was exhausting, and you didn't want to do it. And could I have been there forever? Totally. But why? And whenever I say that to people, they're like, of course, why would you do that? But when it comes into providers, it's like, well, they're just not being sacrificial enough. It's sort of like how we talk about teachers a lot of the times, right? And so I think there's this culture too that we need to break down around what the real expectations are, and in order to bring providers in and to have a sustainable network, and really plans need to be incentivized to do that as well, because right now, they basically don't have to provide mental health services or reimburse for them if everyone's out of network and paying out of pocket. And so it kind of doesn't really behoove them to go into. So I think it's both incentives to providers, but also incentives to payers, and really making sure that they understand the utility of these things. And I'd love to say that those things are both a mix of carrots and sticks for the payer side. I think it's both.
Mm-hmm. Those are excellent points. Yeah. Yeah, I think on the physician side, not as in psychiatry physician, but other physicians, it's up to something like 76% of physician practices are now owned, right, by some sort of corporate entity, hospital system, a health insurer, or something like that. And so the mom and pop private practices on the physician side of the house are being bought up left and right. And I do wonder if at some point that's going to happen with mental health practices too. I don't know, but anyway.
There actually are some movements where larger entities have been buying up mental health practitioners and joining on. And so you do see some national networks that have, now they have a lot more care management type of focus. And so they've received very high contracts with their insurance companies to do that. So some of them even guaranteeing a mental health provider within 24 hours of, request. So you are seeing a little bit of that. It's still slow when it's compared to your medical health. But in some of the slide decks, if you go through them earlier, you'll see very specific points that were mapped out by Lauren or I related to kind of areas for improvement and needs, even those frequency of paying, right? And when you're looking at your insurance, you're looking at sometimes a 2-month delay as a, small, private person, whereas cash, you're getting it that day. and some
Yeah,
folks,
absolutely.
right? And then they do, some of them, that's how they do it. So
Mhm.
it's not helping them to have their own stability too. So there's lots of those little recommendations that are built into those slide decks as well. And Becky put
Yeah.
down that in Oregon, when they raised their rates 30%, it definitely brought in more providers, right? So
Yeah, it helped a lot. We just need more on the Medicare side.
And I think carrots and sticks, as Lauren had said, just to be honest, for everyone related to that. So of course with providers, of course with provider plans, commercial insurance plans, but also with providers, so that they understand too. Because again, I think sometimes we see folks go into these other, more direct payment models for other reasons too, because they're not being monitored. They don't need to be providing certain standards of care. So they can look at and do things differently too. And we've seen that in some of our reviews at the state level. When we look at, well, which providers are actually having more complaints, what's happening with that, what are they missing? They are not providing evidence-based care also. And so because they're not getting any of those reviews, right?
Yeah, I think we see that. I mean,
Mhm.
that's sort of been a known problem, especially in the addiction space. And I think considering how maybe this isn't a stick, but like extra requirements or things that like licensure or certifications and sort of tying that to the training and recurrent training and things that happen. I know that going through like the boards are like a pain in the butt, but I think in California anyway, like we have licensure requirements on all sorts of mental health practitioners. And we don't have them in addiction care. Like that's a problem. People should know that when they seek care and they're seeking mental health and substance use disorder care from a provider, that provider has the qualifications and is treating them to the clinical standard, and we should be reimbursing to that clinical standard too. So I think, keeping the clinical models of care, the clinical levels of care as the like rooting force on both sides it's actually, I think, a helpful way to have more of a streamlined process between provider and payer, or that's the goal anyway.
And we need to be looking at maybe even teaching these pieces within our educational and training programs, where we don't do a lot when it comes to educational systems and really bringing providers. We're teaching them, of course, evidence-based practice, hopefully in care, but then the business side of care, of coding, documentation, commercial insurances, understanding the awareness of the benefits and risks of all that, we don't do a lot of teaching in. So I also think in our educational and training and guilds, being more collaborative and transparent with those pieces can also help some of our new workforce come up and make different decisions.
Yeah, definitely utilization management, right? And making sure that they're getting people progressed towards lower levels of care is the big one. One of the things that we started doing is after 26 visits, we're not restricting continued care, but we do want to do a utilization management review and make sure that they're progressing. So, yeah.
Megan, you make a great point of serving on your licensure boards, making sure that there's standards, a rulemaking authority, and that the professionals understand these pieces. Yeah.
We've done some polling, and I serve also on our national associations here in Montana. And predominantly what we're hearing is most of our private practitioners won't take Medicaid because they're afraid of audits. But similarly, none of our graduate schools are teaching people how to do compliant charting, golden thread. I mean, there's no medical necessity. No one seems to understand that. And so I just started developing trainings because I've lived and breathed compliance for so long. And I'm getting like 60 to 100 people every 2 months signed up for these things, which is crazy. And we're running them through our associations at like $10 a pop. And so our association membership is building, and then we're leveraging those numbers to get an audience with state officials. It's weird. I'm just going to go with it for now, but
I think that's a very common experience. Again, there is a lack of that type of, applied training often in our educational systems, especially for mental health providers I can speak to at least. There's actually been a number of different presentations that have been done on different types of mental health practitioners and how different their training requirements are, and the areas and gaps of those training requirements. And consistently across the board, there are gaps related to evidence-based care still for all of our licenses, mental health licenses, and our educational standards of care, and also related to billing and documentation. And so it's not uncommon, right? Like, so it's very much needed, very much needed. And again, this could be another area that these commercial payers can help with, right? They can help support the training and quality care.
Well, the reality is they absolutely have to be if they're going to be touting quality care and doing payment incentives based on those things. They sort of have to ensure that themselves in order to stay compliant.
And that's a piece
Well,
of
I
putting
want to.
some pressure for them to be able to do so. Jeff?
Yeah, I was just going to say, I want to thank you both for sticking around to, field more questions too and discussion. This was great. And I think, this is maybe our 8th event or something like that. And it was the most interaction that we've had in any of the events. So I think people are really, really appreciated your content. So thanks again to Lesley and Lauren for that. Any other final questions, comments that people want to make here before we let our presenters go?
I was just going to say it's the first time I've gone on, and I got the notice. Dr. O'Donnell sent it out 2 days ago, and the heads of some of our largest networks were like, "Oh my God, I wish I would have known. I would have hopped on." I mean, I'm talking our largest networks in the state of Montana, including heads of our Medicaid system. I mean, we're so desperate for resources and evidence base, and all of our institutional knowledge has left, right? Like nobody wants to put up with anything anymore. So everyone's leaving, including at the rulemaking level. And so we're just chasing our tails. And so I just thought this was incredible. And I wish I could have had you guys on the calls that I had with the state the last 2 days, because they would have, oh God, they would have been in heaven. Just thank you so much. And if it can open up, I know a number of networks that would just eat this up.
And this was recorded, and so we are we will have a recording that people can view, and it's freely available. The more people that want to watch it, the better. So yes, Becky has a question here. Am I able to invite people in my organization to this too? Absolutely. Yeah, it's anybody. You can invite your uncle if you want to. They don't even have to be a mental health provider. So yeah, just you want to go to the website for that you use to register for this event, and just send that link, the website, the URL, to whoever you want to invite, and they can just click which future event they want to be registered for, and then email reminders will come out, like a week or so before the event to everybody who's registered. And then we'll have recordings available at some point here. We don't have them quite yet, but we'll have recordings available for people to access later too if they registered for the event. So
awesome. Thank you. I know we're trying to figure this stuff out too. So yeah, good information. Thank you.
Mm-hmm.
And we put the slide deck back in the chat box so people can download it if you'd like. So thanks, everybody.
Thank you.
Yeah, thanks everybody. And actually, before we go, I'm going to put the link that I just mentioned into the chat box here. So if you want that link for registering, if you want to be able to pass it along to people, I'll put it in here. Okay. All right. Thanks again, everyone. Thank you, Lauren. Thank you, Lesley, our experts. Really appreciate your time. Very generous of you. Are you there, Ron? Dr. O'Donnell, are you there? Might be in a meeting. If you can hear me, thanks for holding down the fort.